Welcome to the deep dive. We know that figuring out health information can be, well, pretty overwhelming, maybe even a bit scary, especially when it's about something as critical as your brain health. So, our mission today is simple. Take some important medical guidelines and break them down. We want you to leave feeling clearer and more confident when you talk to your doctors and nurses. We're focusing today on something called narrowing of the carotid arteries. Okay, let's unpack this.
Exactly. We're looking at how doctors manage what's technically called carotid artery stenosis. That's stenosis. Think of these arteries in your neck as the main highways delivering blood to your brain. Super important. When they get narrowed, well, that's a big risk factor for stroke. So yeah, it's a major concern.
And we're drawing on some solid information today, right?
Yes, we're using the latest updated guidelines from the Society for Vascular Surgery. These are the leading experts. And what's really interesting, I think, is seeing how these recommendations change over time based on the newest research. It's all about getting the best care for patients. We're basically going to hit 5 key areas today.
Okay.
1, when do we think about surgery if there are no symptoms? 2, if you do have symptoms, is surgery or stenting better? 3, what's the best timing for treatment if you've had a recent stroke? 4, screening. Who needs it and how? And finally, number 5, what happens if you've got issues with both your carotid arteries and your heart arteries?
Right, that's quite a roadmap. It really covers the key questions people face. Let's dive into that first one then. What if tests show there's significant narrowing in those neck arteries, but honestly you feel fine? No mini strokes, no stroke symptoms at all. Should you still think about doing something?
Yeah, that's probably one of the most common questions we get, and it's a big one. So for people with quite a bit of narrowing, we're talking more than 70%, but who are generally healthy and low risk for an operation, the guidelines are actually pretty strong. They recommend a specific surgery called Carotid Endarterectomy. That's endarterectomy.
Okay, endarterectomy. What does that actually involve?
Think of it like physically cleaning out the plaque, the blockage, from inside that narrowed artery. Almost like, roto-rootering a pipe in your house to get things flowing smoothly again. And this surgery, plus the best medical therapy, things like medication for blood pressure and cholesterol, is recommended over just the medical therapy alone. The goal is long-term prevention, reducing the risk of stroke and even death down the line.
So it's really about being proactive, isn't it? Even when someone feels okay right now. But I imagine for someone without symptoms, the idea of surgery still feels like a pretty big deal. What's the tipping point there? Why take that step?
That's a really important point to make. It absolutely is a big step. The crucial factor here, the real key, is that for this surgery to make sense in someone without symptoms, the risk from the surgery itself has to be very, very low. Specifically, the guidelines say the risk of stroke or death around the time of the procedure should be less than 3%.
Less than 3%. Okay.
Exactly. Think of it maybe like a warning light flashing on your car's dashboard. The car's still running fine, right? But that light signals a potentially serious issue. So fixing it proactively makes sense, but only if the repair itself is super safe and unlikely to cause immediate problems.
Right. The fix can't be riskier than the current situation, especially with no symptoms.
Precisely. You're constantly weighing that long-term benefit preventing a future stroke against any immediate risk from the procedure itself. It's a careful balance.
Okay, that makes sense for the asymptomatic situation. But let's shift now. What if someone has had symptoms? Maybe a mini stroke, what doctors sometimes call a TIA, a transient ischemic attack, or perhaps a full stroke, and it's linked to that carotid narrowing. Now we hear about options. There's the surgery you mentioned, endarterectomy, but also stenting, right, where they put in a little mesh tube. Which way do the guidelines lean for people with symptoms?
Right, so now we're talking about symptomatic patients, people who've definitely had an event, like a stroke or mini stroke. If they have significant narrowing, and here, significant usually means more than 50%. The guidelines, again, have a strong recommendation. They recommend the surgery, carotid endarterectomy, over a common type of stenting called transfemoral carotid artery stenting. That's transfemoral.
Transfemoral, meaning they go in through the leg.
Exactly. That's the procedure where they thread a catheter, usually starting in the femoral artery in your groin, up to the neck, and place the stent, that little mesh tube, to hold the artery open.
Okay, but hang on. It feels a bit counterintuitive, doesn't it? Why choose open surgery over putting in a stent, which sounds less invasive, especially if someone's already had a stroke?
Yeah, I understand why it sounds that way. It's a really critical distinction, though. What the big studies have shown, pretty consistently, is that the surgery, endarterectomy, generally carries a lower risk of causing another stroke or death right around the time of the procedure compared to that transfemoral stenting.
Ah, so it's about the immediate safety profile.
Primarily, yes. Now, stenting might have a slightly lower risk of causing a heart attack during the procedure. But when you look at the main goal here, which is protecting the brain, preventing another stroke, is considered the absolute most critical outcome for preserving someone's long-term quality of life, their independence.
Okay, that makes sense. So the analogy, maybe if the pipe is already leaking and causing damage.
Right. If you have a clogged pipe that's actively overflowing and causing water damage in your house, that's like having symptoms. You've got options. One is a really thorough repair where you physically remove the blockage, that's the surgery. The other is inserting a device to prop the pipe open, that's the stent. And while the prop might seem easier for this really critical pipe that's already causing trouble, the evidence suggests that the direct cleanout, the surgery, does a better job immediately at preventing more major leaks, or in our case, another stroke.
Got it. What about other types of stenting? Are there newer methods?
Yes, absolutely. There's a newer approach called Transcarotid Artery Revascularization, or TCR for short. With TCR, they access the carotid artery directly in the neck, not from the leg. It has some potential advantages, like better ways to prevent debris from traveling to the brain during the stenting. But for now, especially for patients with symptoms who are otherwise low risk for surgery, the guidelines still favor the established surgery, endarterectomy. We just need a bit more long-term data comparing TCR directly to surgery in this specific group.
Okay, so surgery is generally preferred for symptomatic patients with low surgical risk. Now, what about when to do it? If someone unfortunately has a stroke linked to this narrowing, is there like a golden window for intervention? Does the timing really matter that much?
Oh, it matters hugely. Timing is critical. For patients who had a recent stroke, but importantly, a stable one, meaning their neurological symptoms are mild or moderate and they aren't getting worse. For those patients, carotid treatment, usually the surgery, is recommended relatively quickly.
How quickly?
The guidelines suggest intervening as soon as the patient is stable from a neurological standpoint, which is often after about 48 hours, but definitely before 14 days from when the stroke symptoms first started.
So between 2 days and 2 weeks.
Exactly. And performing the surgery, endarterectomy, within that first 2-week window is generally preferred over stenting for these stable stroke patients.
Why that specific time frame? What happens if you wait longer?
Waiting longer than 14 days, the risk of having another stroke actually starts to climb significantly again. So acting within that window is key for prevention.
But is intervention always the right immediate step after any stroke?
No, and that's a crucial point. Intervention is not recommended right away for patients who've suffered a disabling stroke, meaning it's severely impacted their ability to function, or if a very large area of the brain was affected by the stroke, or if their level of consciousness is altered.
Why not intervene then?
In those situations, doing the procedure immediately carries a much higher risk of causing bleeding within the damaged area of the brain, which can be devastating. So for those patients, the approach is usually to wait, let the brain recover and stabilize, and then they can be reevaluated later to see if intervention becomes appropriate if their condition improves.
It really sounds like a delicate balancing act.
It absolutely is. And think of it like recovering from a major physical injury. You want to do things to prevent re-injury, sure, but you have to wait until the body is stable enough to actually handle the intervention. Rushing in too early can definitely cause more harm than good.
This conversation naturally leads to thinking about prevention and detection. It raises a big question for many of us. Should we all be getting screened for this carotid artery narrowing, even if we feel perfectly healthy? You know, we often think more screening is always better, find things early. But what do the guidelines say about that?
That's a really insightful question, and it touches on a common assumption. The guidelines are actually very clear on this. Routine screening for carotid artery narrowing in the general population is not recommended.
Not recommended for everyone. Why is that?
Well, it comes down to numbers, really. The prevalence, meaning how common significant narrowing is in people without symptoms or major risk factors, is actually very low. We're talking less than 5%. So if you screened everybody, you'd end up doing a huge number of tests to find only a few cases. More importantly, you'd get a lot of sort of borderline results or false alarms.
Which could lead to anxiety.
Exactly. Anxiety, maybe more tests, and potentially even unnecessary procedures that themselves carry risks. It's a classic example where widespread screening just doesn't provide enough benefit to outweigh the potential downsides.
It protects us from overtreatment, in a way.
That's a great way to put it. Guidelines help avoid both undertreatment and overtreatment. Think of it like this. Trying to find one specific rare weed by searching an entire, vast, healthy field isn't very efficient, is it?
No, not at all.
But if you know certain patches of the field have had pest problems before, or have specific soil conditions that favor weeds well, then targeted weeding in those areas makes perfect sense.
Okay, so if general screening isn't recommended, who are those high-risk patches who should be considered for screening?
Right. Screening is considered appropriate for certain selected high-risk groups, especially if finding significant narrowing would actually lead to considering treatment like that surgery we discussed.
And who falls into these high-risk groups?
The key groups include people who already have known peripheral artery disease or PA that's narrowing in the leg arteries. Also, patients scheduled for major heart surgery, specifically coronary artery bypass grafting or CABG.
Okay.
Then individuals aged 55 or older who have at least 2 traditional risk factors for artery disease, things like high blood pressure, high cholesterol, diabetes, a strong family history. Active cigarette smokers who are 55 or older are another group. And interestingly, people who've had a brain scan for some other reason, and it shows evidence of a past silent stroke, what doctors might call a clinically occult cerebral infarction, even if the person never felt any symptoms.
A silent stroke.
Wow.
Anything else?
Well, sometimes a doctor might hear a specific noise when listening to the neck with a stethoscope. It's called a bruit, pronounced B-R-O-E. It's sort of a whooshing sound.
Ah, I've heard of that.
Yeah, hearing a bruit doesn't automatically mean there's severe narrowing, but it does increase the likelihood, so it might prompt screening in someone with other risk factors.
Are there situations where screening is explicitly not recommended, even if it seems logical?
Yes, the guidelines specifically mention a couple. Routine screening isn't generally recommended just because someone has an abdominal aortic aneurysm, that's AY, or aneurys, a bulge in the main artery in the belly if they don't have other carotid risk factors. Same goes for people who've had radiation therapy to the neck in the past, unless they also have other significant risk factors from that list we just covered.
Okay, so for those specific high-risk groups where screening is appropriate, what's the best way to do it? What kind of test?
The clear recommendation is for a duplex ultrasound.
Yeah.
That's DOO-plex. It's basically an advanced ultrasound specifically designed to look at blood vessels and measure blood flow. Critically, it should be done in an accredited vascular laboratory to ensure quality and accuracy.
And why ultrasound?
Because it's very safe, no radiation. It's highly accurate for detecting significant narrowing when done well, and it's much more cost-effective compared to other imaging options.
Like CT scans or MRIs?
Exactly. Things like CTA, which is a CT scan with contrast dye, or MRA, an MRI version, are generally not recommended for screening because of the higher cost, and in the case of CTA, the radiation exposure and potential kidney issues from the dye. Duplex ultrasound is really the go-to test for screening the carotids.
That's very clear. Targeted screening for high-risk folks using duplex ultrasound. Now for a final point, let's tackle a really complex situation. What happens if someone has both problems? Significant carotid artery narrowing, and they also need heart surgery, like that coronary bypass graft, the CABG you mentioned. How do medical teams even begin to decide what to fix first? Or do they tackle both at the same time? It sounds like a real puzzle.
It absolutely is a complex puzzle, and there isn't always one single right answer. But the guidelines do provide some important direction. For patients who have had symptoms from their carotid narrowing, remember that 50 to 99% blockage range, and they also need coronary bypass surgery. The guidelines suggest it's reasonable to perform the carotid surgery, the endarterectomy, either before the heart surgery or actually at the same time as the heart surgery.
Before or during? Why that timing?
The thinking there is to try and reduce the overall risk of stroke happening during or shortly after the heart bypass operation itself. Heart surgery carries its own risk of stroke, and having a tight carotid artery can increase that risk further. So fixing the carotid first or concurrently aims to minimize that danger.
Okay, that makes sense, prioritizing brain protection during a vulnerable time. Does that apply to asymptomatic patients too?
It's suggested for certain high-risk asymptomatic patients as well, specifically those with very severe narrowing, like 70 to 99% on both sides of the neck, or someone with severe narrowing on one side and a complete blockage on the other side, if they also need CEV. In those cases, too, doing the carotid procedure before or during the heart surgery is often considered.
But it sounds like the exact order, carotid first, heart first, both together, isn't set in stone.
Definitely not. The exact sequencing is a highly individualized decision. It really depends on the patient's overall health, the specifics of both the carotid and heart disease, the urgency of each procedure, and frankly, the experience and protocols of the medical center and the surgical teams involved.
So lots of factors go into that planning.
Yes. And the choice between using surgery endarterectomy versus stenting for the carotid artery in this combined scenario is also individualized. It depends on things like, the planned timing, whether the patient needs to be on strong blood thinners for their heart condition, the specific anatomy of their arteries, and other patient-specific characteristics.
It really sounds like a case where a multidisciplinary team approach is crucial.
Absolutely. You need the vascular surgeons, the heart surgeons, cardiologists, anesthesiologists, all talking together. Going back to our house analogy, imagine you need major repairs to both the main water line and a critical part of the foundation.
Okay, two big jobs.
Right. Sometimes you absolutely have to fix one before the other to prevent more damage, maybe fix the foundation before the heavy waterline work. Other times, maybe you can coordinate and do them efficiently at the same time. The best plan depends entirely on the specific problems in your house and what the experienced construction crew your medical team recommends based on their assessment of your unique situation.
That's a great analogy. It highlights the complexity, but also the tailored approach needed.
Well, we have certainly covered a lot of important ground today, from understanding when to intervene even without symptoms, right through to these really complex combined heart and carotid issues. I think the biggest takeaway for me, and hopefully for you listening, is that understanding this information is incredibly empowering. It gives you the tools to have better conversations.
Exactly. These guidelines are fantastic resources for doctors. They provide a solid framework based on evidence, but they also really highlight that your situation is unique.
They're guidelines, not rigid rules. Precisely. And they emphasize just how important shared decision-making is. That conversation between you and your healthcare team is essential, especially in those situations where the best path isn't completely black and white, where the benefits and risks need careful weighing. Hopefully, you now have a much stronger foundation to understand the why behind the recommendations your doctor might make.
So what does this all mean for you, the listener? It means you can take this knowledge, these insights, and use them. Use them as a starting point for your questions, for discussions with your care team. This deep dive, it wasn't just about spitting out facts. It was really about giving you clarity so you can feel more confident and play an active role in managing your health.
And maybe this leaves us with a final thought, or rather a question to consider. How can we, as patients and caregivers armed with this deeper understanding, continue to build strong partnerships with our medical teams to ensure we're getting the very best possible care tailored to us?
That's a powerful question to reflect on. Thank you so much for joining us for this deep dive. We really hope you found it helpful. Feel free to revisit this information and definitely bring any questions it sparked to your own doctor or healthcare provider. Stay informed, stay well, and we'll catch you next time on the deep dive.